So first of all, thanks for the introduction. It's nice to see a few friendly faces out here. I want to thank Curatus for giving me the opportunity in our laboratory to do this study. They've been great partners with us. And I want to thank you guys for doing something here right before the meeting even starts. And if you've had a chance to see some of the other talks today, but to conclude the industry-sponsored talks. I need to thank a few people who are integral in being able to share with you the data that we're going to share today. So I'll direct your attention down here. Ben von Bredow is our clinical microbiology postdoc at Hershey Medical Center. Colleen Lowe is one of our two senior technologists. Heidi Reinhardt is one of our fourth-year pathologists, one of our chief pathologists. Debbie Myers is our supervisor in microbiology. And then Corey Hale, who is the co-director of our antimicrobial stewardship program, is going to play a very integral role in this. He is the person that sort of consulted with me as we had these results to make some decisions on what the stewardship outcomes would be with these results. And so that's going to be the focus of the talk today. So, disclosures. I live in the sweetest place on earth, Hershey, Pennsylvania. Otherwise, this is a Curatus sponsored research protocol. I have not received any personal honorarium for my talk today. Okay, so what are the objectives? We want to evaluate the performance of the Unyvero lower respiratory tract panel on the Unyvero system compared to conventional bacterial culture for sputum and tracheal aspirate specimens. Our first of two aims is to compare the detection and identification of bacteria and antimicrobial resistance genes for the Unyvero LRT panel, compare those to conventional culture, our routine standard protocols, and our antimicrobial susceptibility testing. Our second aim is to identify the potential impact on antimicrobial stewardship related to the turnaround time of these results as compared to our conventional culture methods. Okay, so just a little bit about us. The Penn State Hershey Medical Center is the medical center and College of Medicine for the Pennsylvania State University system. We are a 520-bed tertiary care level 1 trauma center, which includes a pediatric hospital, expanding as we speak from 3 floors to 6 floors, and a cancer institute, all under one roof. Our hospital is the teaching hospital for our College of Medicine. So what is our protocol? We have worked with Curatus to say that we would identify up to 1,000 respiratory samples that were submitted to our laboratory for routine standard of care culture, and then enroll up to 200 of those specimens for the study itself. The inclusion criteria for being included in the study include existing pathology specimens, sputum and trach aspirates. These would be people who are inpatients in our facility, or in one case that I'll talk about today, a patient who moved from the ER and was admitted as a result of their presenting respiratory distress. And we decided to keep at least 2 mLs of specimen available, far more than what's needed for this test, but just to have additional specimen for repeats if needed and or discrepant analysis. Exclusion criteria for the study includes our cystic fibrosis population, our non-hospitalized outpatient population, and then any specimens in which we could not attain 2 mLs to keep in store for future studies. So we did a look in preparation for setting up this protocol as to what our common organisms were in our respiratory secretions. This was a snapshot of respiratory secretions per annum. Those numbers may look a little bit small, but again, there are a lot of specimens that were excluded here. But for the sake of just orienting you to what our laboratory might look like in comparison to your laboratory, not surprisingly, Staph aureus, Pseudomonas aeruginosa, H. influenza, M. catarrhalis, and from that point on, smaller numbers. But I suspect much like your own clinical microbiology laboratories. Our protocol is that our sputum and trach aspirates are gram stained and assessed for quality of specimen. We use the typical criteria that most laboratories would in terms of ratios of EPIs to PMNs. Those specimens that are assessed and accepted for culture are plated. Our protocols are 3 days for incubation. Our plates are read daily and reported as no growth to date or as preliminary reports with appropriate identification or susceptibility test results at that time. Our preliminary results are posted until a final report at 3 days. Our identification protocols are mass spectrometry protocols, so all of our IDs are by MALDI-TOF now. And our antimicrobial susceptibility test capability is a commercially prepared microbroth dilution panel. And then lastly, our culture and AST results are reported into the lab information system. Okay, so here is the system, if you haven't had a chance to see it. And I'll go through and talk just a little bit about each component of this 3-component system. So first component here on the far left, whoops, it advanced for me, but that's okay. On the far left, you'll see the lysator. The lysator performs pre-treatment of native patient samples. So this is where specimens are liquefied, where samples are lysed to release the nucleic acid, and then homogenation takes place. The cockpit is basically what they say is an intuitive central user interface in which you just follow the run. No parts of the test are being performed on this other than the monitoring of the test, and then the analyzer does extraction, purification, amplification, and detection of the DNA. And there's a cassette that goes into that analyzer. And the system processes 2 cartridges at a time in random access fashion, which are modular and scalable for higher volume throughout. We currently have 2 systems in our laboratory supporting this study. So this is sort of where the works. The cartridge here, it's fully barcoded with positive ID, and you can see here the chemistry all takes place in the amplification in here. Won't read this to you, but that's where in that cartridge all the work, all the chemistry is being done. It's a single-use cartridge. It's self-contained with reagents, fluidic systems, the PCR, master mix, and detection wells, along with a waste reservoir, all in that one cartridge. And these are the analytes, if you will, that are detected by the Curetis Unyvero LRT pneumonia panel. You'll see that there are 19 bacterial targets and 10 antibiotic resistance markers for a total of 29 clinically relevant bacterial pathogens and antibiotic resistance markers. You'll see a number of pretty friendly faces up there, a number of the family of the Enterobacteriaceae, 3 of the most predominant glucose non-fermenters to include Stenotrophus multifilia, and the atypical bacteria are also here, Legionella pneumophila, Mycoplasma pneumoniae, and Chlamydia pneumoniae. On the susceptibility test side, there are 10 different antibiotic resistance markers to include a number of markers associated with carbapenem resistance, along with a CTX-M, which can help with the use of third-gen Cephs, so much like an ESBL marker. Obviously MEC-A for staphylococci, and TEM for penicillin resistance. So all of those are available within this cartridge. Okay, so the protocol is relatively straightforward. 2 minutes hands-on time, direct from the sample. Software provides on-screen instructions to start the test. It's a rapid, high-utility, qualitative result based on inherently quantitative algorithms, and we'll talk about quantitation and so forth as we move throughout the talk. And then I've summarized briefly under each of the 3 areas there, sort of the hands-on piece of this. I'll highlight on the pre-treatment of the sample that we'll take 180 microliters of the Vortex patient specimen. That's what ends up in the sample tube that goes into the cartridge. over to the second group there. When the lysis is complete, that sample tube is then put into the cartridge, and on the other side of the cartridge is the PCR master mix, so 2 different insertions into that cartridge. The cartridge is then loaded, and the results are reported. So this is a result summary report. I'm going to show you 3 different screens as we move through this. On this particular one, you'll see the presence of Haemophilus influenzae detected. You'll see a corresponding resistance marker here. It's a TEM, and then it tells you what type of antimicrobial that this suggests that there would be resistance to. You'll also see other organisms that were detected in this particular run. The microorganism report shows a positive result by, in this case, for a Klebsiella pneumoniae under the Enterobacteriaceae side. There's also a separate readout for the gram-positives, for the non-fermenting bacteria, and for the other organisms that are there. And again, you can see positives along with the Kleb pneumoniae, with Strep pneumoniae, Pseudomonas aeruginosa, and Haemophilus influenzae. So very intuitive, very easy to follow in terms of understanding what these results are giving us. And then lastly is a result detail report in which you also can see, in accordance with the organism themselves, what appropriate antimicrobial susceptibility test markers are available, what applies to what organisms. We don't want to apply something like MEK-A against the Kleb pneumoniae. So again, organized very easily for you to follow the susceptibility test results, or at least the genetic markers associated with the organisms that are identified. Okay, so I want to summarize what we have done to this point. We are still in the middle of accruing those 200 samples. Right now, we're at 114 samples. Those samples have sort of 3 different ways in which they can be processed, sort of 3 different tools, if you will, which we could discuss potentially after the talk. By the way, 2 of the folks that I referenced on the title slide who did most of the work, Colleen and Ben, raise your hand real quick. If you guys want to talk to operators and find out what this is really like and how you use it in a workflow, they're here to have that discussion with you all today if you would like to do that. After taking out repeats and or organisms that for whatever reason we didn't include in the analysis today, we currently have 86 individual non-duplicates. So some of the tests that we ran might have been on the same patient, some might have been repeats on the same patient, but I'm going to show you the data crunching that I do today, the little bit. I'm not going to do a lot, but the little bit of data crunching that I'm going to do today is based on those 86 test results. And I tried to think about how to do this. Most talks like this will talk about sensitivity, specificity, predictive values for positive and negatives. I thought it'd be really interesting to hone in on the rapid detection capability and what impact this would have on stewardship. So I sort of came up with this criteria of a match. And here's sort of what that looks like. If I called something a match with an equal sign, I call that a match equivalent. And what that means is that everything that we grew on the culture plate is entirely represented by what the result from the Unyvero test result was. No differences whatsoever. Very easy, very straightforward, and about half of all of our samples did that. Then I categorized a certain number of organisms in what I called match plus. So a match plus is information that is equivalent between the Unyvero test and our culture results, but also yielded additional information on the Unyvero test. And I'm going to go through 6 cases with you, and I'm going to give you examples and so you can see what this looks like, and we'll talk about the implications of having that additional information. And then lastly, a very small percentage, but what I will call a match negative, in which there were less results on the Unyvero than what we specifically identified and confirmed and did susceptibility test on by conventional methods. So match equivalent, match plus, match negative is sort of the way that I've decided to approach this. We currently have 4 specimens which are discrepant upon repeat testing, and again, that extra 2 milliliters will help us go back with a third-party adjudicator and figure out what those results really are. Interestingly enough, to this point, we haven't had a chance to look at this very closely, but all of the 4 discrepants are all culture positive, Unyvero negative, and they all deal with relatively small amounts of Staph aureus. So we're going to go back and take a look at this closely and work with Curatus to figure this out. So that should equal 86. All right. To me, this is the most important slide in terms of interpreting what we're trying to do today. So I work very closely with, all of our laboratory works very closely with our antimicrobial stewardship program. We are one of 25 IDSA certified antimicrobial stewardship programs in the United States. And so I reached out to our stewardship and I said, what are the treatment algorithms for lower respiratory disease, and how would these results impact the way that you would help our clinicians manage these patients? So most of these are going to follow along IDSA guidelines. Some IDSA guidelines are a little old, but basically this follows those guidelines. So for community-acquired pneumonia presentation to our hospital, those patients are going to get ceftriaxone plus either azithromycin or doxycycline. If ceftriaxone can be de-escalated, it will typically be de-escalated into high-dose amox and or amoxiclav plus erythromycin, or potentially all the way down to, azithromycin, or potentially all the way to azithro or moxifloxacin. This healthcare-associated community-acquired pneumonia is a bit of an old term. It's sort of fallen out of favor in terms of the way we look at potentially hospital or ventilator-acquired pneumonias, but I kept this in because one of our 6 cases sort of reflexes better to this algorithm than it does the others, so I thought we would keep that in there. So once you get into the healthcare-associated things, you're worried about things like Pseudomonas and Staph aureus, so our old guidelines for health-associated community-acquired pneumonia would have included vancomycin and piptazo. And now for hospital-acquired pneumonia and ventilator-acquired pneumonia, which again, we want to cover Pseudomonas aeruginosa and MRSA, we would use vancomycin plus piptazo or cefepime. If the patient is really sick, for example, a septic patient that presents, we would add a fluoroquinolone or potentially an aminoglycoside. And then if we have an opportunity to de-escalate from vancomycin, we're typically going to de-escalate to piptazo and cefepime to cover the other gram-positives and also to give us some coverage for some of the gram-negatives, potentially the cefepime and piptazo, even to cover a Pseudomonas. So as I go through our 6 cases, I'm going to refer to these and say, this is what we would call these upon presentation. This is how these patients would be managed. And now we'll talk about how the patients might be managed differently with more rapid results from this test. Okay, so case number 1. This is a sputum specimen from a 63-year-old female who was an outpatient who came into the ER and was subsequently admitted. Our gram stain, and you'll notice from this point on, I'll talk about time. Time is important, and so I've made some sort of guesstimates on how long it might take to get that gram stain out. We'll make some guesstimates on how long it would take to get the culture result out, the identification, the susceptibility testing, and of course how long it would take for the Unyvero results to be available. So here's our gram stain, and let's just say at about 2 hours, and it's a pretty busy gram stain, and that's perhaps not surprising to most of you all in the room. These respiratory secretions often have a lot of oropharyngeal contamination, one of the complicators and one of the challenges of managing these specimens. So we had a lot of things going on here, and the PMNs are there at 2+, not overwhelming, but clearly there. And in 5 hours, what I have from this specimen is a result of H. influenzae that is positive for the TEM marker, suggesting resistance to beta-lactams. So the following day, I just chose 20 hours. Some would say 24 to make it easier. It's rare that it's quite that many hours, depending on what time of day the specimen arrived in our laboratory. And in this particular case, we grew 2+ Haemophilus influenzae that was beta-lactamase positive and 2+ normal respiratory flora. So looks a whole lot like what the gram stain suggested that we might see. We weren't sure if we'd see a predominant guy. here, and indeed the H. influenzae is in the same quadrant with the rest of the normal respiratory flora, but a number of more colonies of this. And of course, when you look at that chocolate plate and you see that thing staring at you, you pay attention to that. So that was the report that went out at 20 hours. So here are my comments on what these results mean and how this would be managed in terms of stewardship. So this is a match equivalent. What we saw in the culture and what we saw in the Unyvero is exactly the same. We did a rapid beta-lactamase test, as I'm sure the rest of you all would do here. There isn't full susceptibility testing on this. So I've shown here that the Unyvero would give us that result in 5 hours. I've shown here that our culture and our ID goes fast, it's MALDI, so we're going to say that's 20 hours. And the only susceptibility testing we're going to do here is a beta-lactamase, so that's rapid, within seconds. And so basically at 20 hours, we have a result that is exactly equivalent to the Unyvero result. So what does this mean from a stewardship perspective? So this patient would get managed as a community-acquired pneumonia patient, and so they would be on ceftriaxone and azithromycin. Once these results are available, and with the Unyvero test, we would have those results in 5 hours. We could have either stay with ceftriaxone or de-escalate to high-dose amox and or de-escalate to amoxiclavulanate. And if we, since we know we have no evidence for the atypicals, we could de-escalate and stop the azithro or the doxy, depending on which one was used. No evidence for Legionella pneumophila, mycoplasma pneumonia, or chlamydia pneumoniae. So there's case one. So I'd start you out sort of easy, fairly intuitive, can sort of follow this. Not a whole lot of conflict in this one. Let's go to case number 2. So this is a tracheal aspirate. It's on a 3-year-old young girl. And the gram stain here is relatively definitive. When we see this, we're thinking some things that we're going to see the next day on the plate. So we've got 4+ gram-negative diplococci, and in the report we included that some of these were intracellular. There were a few gram-positive cocci and gram-negative rods, and 4+ PMN. So this is a very good specimen, and we would anticipate that our culture would hopefully do a good job of this. The Unyvero captures 2 different organisms in 5 hours, Moraxella cataralis and Stenotrophus multifida. So what do our results say the following day? The following day, we're growing 4+ MCAT, again, following along with the gram-negative diplococci that we saw. It is also a beta-lactamase positive organism. So again, a rapid test there, no additional susceptibility tests, and 1+ normal respiratory flora. Notice we don't see the presence of the steno here, and the question would become, is it part of that 1+ normal respiratory flora? So this is one of those examples in where I call this a match plus. This is where we have information that matches, but there's additional information with the Unyvero that we would not have had if we weren't running the molecular test. And again, much like the previous case, 5 hours to the Unyvero result, 20 hours to the identification, and because it's only a beta-lactamase test, we can complete the susceptibility testing concurrently, so 20 hours in total to be able to report this out. So what does this mean for stewardship? So again, similar to what we saw in the previous case, this little 3-year-old is going to get ceftriaxone and azithromycin for community-acquired pneumonia. For the MCAT itself, ceftriaxone could remain on board or could be de-escalated, much like that H flu was. There was beta-lactamase positive to amoxiclav or potentially amsulbactam. We're going to stop the azithro and or the doxy if used. We don't have any evidence for atypicals. And so what about that Stenotrophus multifida? If someone thought that that was important, obviously probably prophylactic or adding trimethoprim sulfa would be added to the coverage for this young girl. We believe, based on looking at the plates, so we went back and we looked at, we had everyone store these plates so that as we looked at what the Unyvero gave us, we could go back and look critically again to see is there any evidence. And in this particular case, we would say no. We would say that like a lot of other things in that busy normal respiratory flora, we don't see anything that we're going to pick or dig out of this. Don't want to get into that business. So we believe that this is a colonizer of that trach aspirate, and there's no clinically relevant evidence that would suggest that we need to react to that Stenotrophomonas multifida therapeutically. So that is report number 2. Let's move on to report number 3. So this is a sputum specimen from an 80-year-old female inpatient. The gram stain here, again, pretty convincing for certain things that we think we'll be able to grow and see. So 4+ gram-negative rods, a few gram-positive cocci in the background, and 3+ PMNs. Unyvero yielded Stenotrophomonas multifida. On our culture plates, we grew 3+ Stenotrophomonas multifida and 1+ normal respiratory flora. So in this particular case, I've called this a match equivalent. What we see in the Unyvero is exactly what we see on our culture plates. Again, 5 hours to report this result versus 20 hours to report the culture and ID. And then for susceptibility testing, that would just, for the math, I decided to add 24 hours for susceptibility testing. Most of you all would know that Stenotrophomonas would probably be covered by trimethoprim sulfa, although there are potential options, and so the susceptibility test does become relevant here. It's rare for us to see in our institution organisms that are resistant to trimethoprim sulfa, but nevertheless, we would want to have that report before we concluded. So what does stewardship say to this? So they would say that this looks like a hospital-acquired or a ventilator-acquired pneumonia in which the patient will be managed with vancomycin and then either piptazo or cefepime plus ciprofloxacin. Upon the release of these results, we'd be able to stop the vancomycin, although they point out that a lot of times that requires a phone call from stewardship to convince them that they can stop the vancomycin. The Cipro could be changed to trimethoprim sulfa or levo, depending on the susceptibility test results. We want to make sure we do get some resistance to levofloxacin in our institution. We could potentially de-escalate everything to levo or trimethoprim sulfa, given that Stenotrophomonas is the only organism that we think is clinically relevant here. And stewardship would probably follow up to make sure that that complicated regimen from the HAP or VAP protocol has been de-escalated appropriately to the one organism that our laboratory believes is clinically relevant. Okay. Let's go to report number 4. So this is a tracheal aspirate. It's a 5-month-old male. It's another pediatric patient. Gram stain here, not as declarative in terms of the organisms that we might be thinking about, but 3+ PMN. So again, a good specimen. I want to see what the culture results provide. Unyvero shows Pseudomonas aeruginosa and Serratia marcescens. The following day, on culture, our culture results yield 2+ Pseudomonas aeruginosa, 2+ Serratia marcescens, and 1+ normal respiratory flora. So this is a match equivalent, a match equal. Same information from the Unyvero and from the culture. 5 hours to the Unyvero result, 20 hours to the culture ID, and an extra day, 44 hours for susceptibility. From a stewardship perspective, their consult was, we're not sure up front with the presentation of this 5-month-old and the gram stain, which isn't very declarative as to whether this would be managed as a community-acquired or a HAP or VAP. So we decided to include both. I sat down and talked with them. What would you do if CAP? What would you do if HAP or VAP? So if community-acquired, we would escalate the ceftriaxone to cefepime to cover the Pseudomonas and the Serratia. And if the patient has not improved, potentially the addition of an aminoglycoside until the final susceptibility test results are available. If managed as community-acquired pneumonia, again, stop the azithro and the doxy. We're not concerned about the atypicals. And we could also stop the vancomycin because there's no evidence for Staph aureus here in any place, the gram stain, the culture, or the Unyvero results. And so I included both of those because you might have a debate about how this patient should be managed. So whichever way you go on this, this is how we would manage the patient and this is how those results could potentially lead to de-escalation. Okay, report number 5. 2/3 of the way through. So this is a sputum specimen. It's a 44-year-old female inpatient. Our gram stain is not very strong. Not a lot of PMNs, a little bit of this, a little bit of that. Again, probably not uncommon to things that you see in your laboratory. Unyvero result gives us 4 answers for bacteria and 1 answer for antimicrobial therapy consideration. So we have a MEK positive Staph aureus, we have Pseudomonas aeruginosa, Klebsiella oxytoca, and Streptococcus pneumoniae. So what did the plates show the next day? The plate showed the Staph aureus and the Pseudomonas aeruginosa and 1+ normal respiratory flora. So okay, now we're starting to get into the more complicated piece of what do you do with this additional information. So this is what I call the match plus. Again, we have more information from the molecular test than we have from our culture test. Again, time frames are the same. And how would this work from a stewardship perspective? How would this be managed? So if this is managed as a community-acquired pneumonia, they would immediately go, and this is that older term, to hospital-acquired pneumonia or the hospital, the HCAP definition, in which ceftriaxone and azithro would be changed over to Piptazo, Cipro, and Vanc. We would attempt to de-escalate to 1 Pseudomonas aeruginosa drug when the susceptibility test report comes out. And PharmD literally wrote to me as sort of a consult and said, it's unlikely for someone being treated as a CAP to culture all of this, but I've been surprised before. So I don't know how much overnight intervention would take place based on these results, because they're used to seeing complicated results from these respiratory secretions, and maybe we need to wait a little bit longer to render a final decision on the appropriate antibiotics. If managed as a hospital or ventilator acquired, then the only change would be that we wouldn't need that second Pseudomonas drug. And again, our PharmD, Corey Hale, said Unyvero would prompt earlier addition of a second drug to cover the Pseudomonas while awaiting susceptibilities and potentially adding Cipro or Gent if not already included based on those susceptibilities. And lastly, what do we do with that Klebsiella and that Strep pneumoniae? We don't have any evidence of the clinical significance of those organisms. We believe they're buried in that normal respiratory flora. And again, we don't dig that out to try and find every organism that is there. Could never do that. No literature, no evidence-based practice that would suggest that would be true. So our conclusion is that the Kleb and the steno were colonizers, not a part of what's going on in the lower respiratory tract of this patient. And lastly, patient number 6. So this is a trach aspirate. It's a 5-year-old female from a pediatric hospital. A very busy gram stain, but a lot of things that are busy. So not just representative of multiple morphologies on gram stain, but representative a lot of multiple morphologies on gram stain. So 4+ gram negative rods, 4+ gram positive cocci in pairs and chains, 2+ gram positive cocci in clusters, 2+ gram positive rods. I'm sure you've all seen a lot of these. 4+ PMNs. If you're like us, you'll see multiple trach aspirates on inpatients day after day, or maybe 2 days, or maybe 3 days, and we get the same result sort of over and over again. And usually the technologist will alert me, and I'll make a call and say, nothing's changing here. And so just don't want you to be confused by these results, and potentially maybe you don't need to send those trach aspirates anymore. Those are discussions that I have periodically with our clinicians. Okay, so we got lots of organisms here. Probably not surprised that we have a lot of organisms here, but okay, what am I going to do with that? How do I manage that? We'll talk about that on the next slide. With a whole bunch of stuff, our cultures sort of were fairly interesting in the sense that we had 2+ Staph aureus. And we have grown used to making a comment, especially in our respiratory and some of our complicated wound cultures, where we make comments like, including mixed gram-negative rods. And we look on the McConkey plate, there's 3 or 4 Enterobacteriaceae, there may be a glucose non-fermenter, we would never work that up, molecular test, culture test, nothing is predominating. So a lot of that is embedded in the middle of that 2+ normal respiratory flora, and the question is, how is this patient going to be managed? So again, I characterize this as a match plus, information that matches the culture result but provides additional results that we need to consider. And again, final out to susceptibilities of 44 hours compared to 5 hours for the Unyvero results. Okay, so this constitutes a whole slide in and of itself for how we're going to manage all of these results from both the molecular test and our cultures. So stewardship points out that this is going to be managed as a HAP or the potential of a HAP or a VAP, and part of that is going to be based on whether the patient is in an acute care ward on the pediatric hospital or in the ICU. So the HAP-VAP, to go that way, is cefepime plus vanc without a 2nd gram-negative drug. There's no evidence anywhere in all of this for MEK-A, so we don't have to worry about vancomycin as long as we're covering for those gram-positives to include that Staph aureus with an appropriate gram-positive drug. So here's what the PharmD consult says on this, and I've just quoted him, and we spent some time talking about this. So his first comment is that I'd want to wait for culture results before reacting to most of the Unyvero results. So in this particular case, let's say you see these results in the afternoon. From a stewardship perspective, they'd say, okay, got a lot of stuff going on here. We know that some of this could be just part of normal respiratory flora. I think we put a hold on this. We don't make any intervention. We wait until the next day, and we start to see if the culture begins to help us figure this out. Primary care team may add trimethoprim sulfamethoxazole for the steno and a 2nd gram-negative drug while awaiting, again, because there are a number of organisms here. He also goes on to say, I doubt that escalation is truly necessary for the patient. In other words, I understand this is probably going to be normal respiratory flora, or a large part of this is, but I don't see stewardship calling the team to stop either drug if they made the decision to start them when we don't know yet quantitatively how important each organism is. Okay? Resistance genes could be helpful, so if we saw a CTXM and we were worried about those Enterobacteriaceae and we were worried about ESBLs, for example, potentially not using the ceftriaxone, and again, under the protocol for HAP and VAP, the gram-negative coverage is going to be either piptazo or cefepime, and that could then be escalated to meropenem if there was evidence for resistance to those other drugs. There's and we know in this test that there's a limitation in the ability to detect ESBLs, ESBL-producing organisms, and so no de-escalation if the patient is on meropenem and CTXM is absent. Obviously, the presence of the CTXM, maybe with a porin, would create a problem with the carbapenems, so all of that is sort of on the table as we react to this therapeutically. For the gram-negative coverage, the stewardship recommendation would be eventually to de-escalate to one drug, be it a 3rd or 4th gen Ceph or a MoxClab, but not until the actual culture result came back with what was predominant and then the susceptibility testing on those predominant organisms. In addition, I'd want resistance genes reported if present to give the patient the benefit of the doubt. Would later be a tough battle to get broader drugs stopped when the culture comes out mixed flora, though. So if they see a very busy result here, they may stick with a full HVAP, HAP or VAP type of coverage, and they may be reluctant to de-escalate even with final results, and a lot of times that's where stewardship gets involved, and we do our reminders at 72 hours. We don't force any changes. We simply make the phone call at 72 hours and say, you know, IDSA recommendations would be you could do this or you could do this. Doctor gets to decide what they do going forward. They just get the phone call from stewardship. Last comment. I think you would run into a lot of issues in the lab with teams calling to request workup on those gram-negative rods in the normal respiratory flora. In this case, I think the lab can make the decision to report something like greater than 5 organisms detected, unclear clinical significance. For questions, contact the microbiology laboratory. Culture results to follow. And this leads into my last slide, my summary slide, in terms of what are some options that you might want to consider in the utilization of this test in your institution. So the first summary statement that I would make about our study to date is that the technology is good. It highly correlates with our culture results. Less than 10% of specimens yielded less information than our culture did. I keep flipping like that. So we've looked at 114 of 200. We have counted 86 of those in our statistics to date. 86% of those rapid results are either equivalent to or equivalent plus the culture with the additional information. We still have those 4 discrepant samples to take a look at. Obviously, rapid results can influence therapeutic management. Many of us in this room have learned that through the use of blood culture rapid reporting. So rapid results can help with an aggressive stewardship program and getting patients to the appropriate antimicrobials as soon as possible. So what are some outcomes with those rapid results? You may get a rapid de-escalation. Showed you at least two examples of that in our 6 cases in which you'd be at final therapy, potentially at 5 hours. You could rapidly escalate. If we see organisms that are not being included, especially if there's discussion between is it community acquired versus VAP or HAP, what do we need to do here? So maybe we go to the increased algorithm to cover for additional organisms such as Pseudomonas aeruginosa and Staph aureus. Strategies for implementation. I have 4 thoughts about implementing this in your laboratory. So this could be simply added as an additional test to the conventional cultures that you're doing on your respiratory secretions and report it like we do blood cultures. We get our multiplex blood cultures out in about 2 hours after a positive bottle. In this particular case, you would have a result out in 5 to 6 hours after the specimen is received. So that would be another option, is simply we have another test that we're going to use in the management of these patients. A second option would be selective use and reporting of these rapid results. So maybe there are certain patients, maybe there are high acuity wards versus lower acuity wards. Maybe there are patients who are admitted from the ER versus patients who have been in the hospital for multiple days. So perhaps you'd work with your stewardship committee and decide, based on the comments that I've shared with you today, what's the best utilization for certain patients, and say maybe those are the patients that we're going to do that with. Those demographics that would help you make that decision, in my opinion, would again be high acuity versus low acuity patients. The selective use would also be potentially based on the gram stain and the total number of organisms detected. So in that last case, we talked about multiple different organisms. Perhaps not easy to know what to do at that point, 5 hours to 6 hours after we have received that specimen. So maybe we just sort of leave that as it is, and we call that sort of mixed flora. That would be another option, so you report less information than you potentially have. You could report all the information and add an interpretive comment, or you could report all the information and add a therapeutic comment. I've had a number of discussions with my colleagues across clinical microbiology laboratories in this country. Actually polled on the ClinMicroNet about 4 years ago before a talk that I did, and I asked my colleagues out there, I said, do you see your role in reporting results as an important role in interpretive comments, or do you see your role as important in making therapeutic comments? And it was interesting, it was split almost in half. Some people felt like that we absolutely should be making interpretive comments in our reports, and I think probably almost all of us would agree with that to some extent. But Many others said we should also have therapeutic comments, have very specific comments that would help direct what that therapeutic, the way those results are reported, to direct with a comment on what the appropriate therapeutic options would be. Maybe half of my colleagues out there at that time would agree that that would be the role of the clinical microbiology laboratory. What I would say to that is, even if you would disagree and say, I don't want to necessarily put that into the patient record, what I would want to do is continue to work with our stewardship team and decide how we want to manage this. At our institution, our stewardship team is constantly providing comments to us that they would like for us to put into our reports. And so a lot of our reports have these standardized text comments that we put into those results. Again, if you have no other way in which you're looking for atypicals, Legionella pneumophila, Mycoplasma pneumoniae, Chlamydia pneumoniae, this would give you an opportunity. I know in our institution right now, our RVP, our respiratory viral panel, has changed its name as an order because it detects more things than viruses. It's an RPP, a respiratory pathogen panel, because it includes some of the atypicals. But if you don't have that in your institution, this is one way to at least be able to rule those organisms out.